Good day, we are Group 4 from BSN 2D and we're going to discuss chromosomal abnormalities, inborn error of metabolism, high-risk infants related to birth injuries. Topics will be discussed by Ms. Bispo Rose Ann, Mr. Cor Ronald, Ms. Dinoy Eliza, Ms. Domapias Regine, Ms. Layson Precious, Ms. Tunggakit Zia, Ms. Paco Erica, Mr. Roma GV, Ms. Rosal Alia, Ms. Tabuco Nicole, and Ms. Villaferte Alia. These are the topics. Cradle-Chat syndrome. Definition. Cradle-Chat syndrome, also known as cat's cry syndrome or 5P- syndrome. Cradle-Chat syndrome is a result of a missing portion of chromosome 5 in addition to an abnormal cry, which sounds much more like the sound of a cat than a human infant's cry. Children with Cradle-Chat syndrome tend to have small head, wide-set eyes, a downward slant to the palpebral fissure of the eye, and a recessed mandible. They are severely cognitively challenged. For the etiology, Cradle-Chat syndrome is a chromosomal disorder caused by a partial deletion or monosomy of a varying length of the short arm P of chromosome 5. Chromosomes, which are present in the nucleus of human cells, carry the genetic information for each individual. Majority of cases of Cradle-Chat syndrome are believed to begin at the time of the development of the egg or sperm. Some cases of this disease also occur when the parent passes a different form of the chromosome to the child. HTERT or human telomerase reverse transcriptase helps to keep the information in DNA functioning properly. If HTERT is damaged, mental illness such as Cradle-Chat occur. Most cases of Cradle-Chat syndrome are not inherited. The chromosomal deletion usually occurs as a random event during the formation of reproductive cells, which is the egg or sperm, or in early fetal development. People with Cradle-Chat typically have no history of the condition in their family. For the disease process, deletion of the end of the short or P arm of chromosome 5, which leads to the chromosome deletion, usually occurs as a random event during the formation of reproductive cells, which is the eggs or sperm, or in early fetal development. A missing of a piece of chromosome 5 affects the development of the infant. For assessment, risk assessment. If there is a family history of Cradle-Chat syndrome, your doctor may suggest a chromosome analysis or genetic testing while your child is still in the womb. The physician may perform an X-ray on your child's head to detect abnormalities in the base of the skull. Also, a chromosome test that uses a special technique called a fish analysis helps detect small deletions. For the signs and symptoms, it is divided to physical features, cognitive, and others. For the physical features, we have facial structure anomalies, downward slanting eyes, delayed growth of the child, abnormally shaped ears, webbing or fusing of fingers, skin tags in front of ear, microcephaly, small jaw, wide-set eyes, vertical skin folds that may cover the eye's inner corners or epicanthal folds, improper alignment of the upper and lower teeth, which is called malocclusion. For the cognitive features, we have cognitively challenged. And for other signs and symptoms, we have peculiar cat-like cry, weak muscle tone or hypotonia in infancy, delayed motor development, extremely low birth weight is also observed, and abnormalities of the kidney and urinary tract. This photo shows an example of an infant who have Quebec syndrome. For the diagnostic test, we have FISH or fluorescence in situ hybridization. It is to visualize and map the genetic material in an individual cells, including specific genes or portions of genes. We also have karyotyping. It is to identify and evaluate the size, shape, and number of chromosomes in a sample of body cells. We also have amniocentesis testing. During pregnancy, it is to detect physical abnormalities such as Down syndrome or Quebec syndrome. Also, X-ray will be performed to detect abnormalities in the base of the skull. For the management of Quebec syndrome, we only have medical interventions. So for the medical interventions, services that may be beneficial include special remedial education, physical therapy, physiotherapy, speech therapy, special services, and other medical, social, and/or vocational services. It is for early intervention because it is important in ensuring that children with Quebec syndrome reach their highest potential. We also have chromosomal rearrangement. The patient carries a chromosomal rearrangement called a balanced translocation, in which no genetic material is gained or lost. Genetic counseling is also recommended for affected individuals and their families. Increase the family's understanding about genetic diseases, the risk and benefits of genetic testing and disease management, and available options. So this is the pathophysiology of Quebec syndrome. We have the predisposing factors, which is the genetics, and for the precipitating risk factors, we have age. We have the etiology and its signs and symptoms divided to physical features, cognitive, and other signs and symptoms. We also have the management, which is the medical management stated, such as standard therapies, chromosomal rearrangement, and genetic counseling. For the second condition, we have the trisomy 13. For the definition, in trisomy 13 syndrome, or also known as Patau syndrome, the child has an extra chromosome 13 and is severely cognitively challenged. The incidence of the chromosome is low, approximately 0.45 per 1,000 live births. Midline body disorder, such as cleft lip and palate, heart disorders, particularly ventricular septal defects, and abnormal genitalia are present. Other common findings include microcephaly with disorders of the forebrain and forehead, eyes that are smaller than usual, which is called microphthalmos, are absent, and low set ears is also observed. Most of these do not survive beyond early childhood. For the etiology or cause, most cases of trisomy 13 are caused by random events during the formation of eggs or sperm in healthy parents prior to conception. Trisomy 13 is typically due to have 3 full copies of chromosome in each cell in a body instead of the usual 2 copies. For its risk factors, a personal or close family history of giving birth to an affected child increases the risk. Also, the risk rises with increasing maternal age, but not as markedly as Down syndrome, or also known as trisomy 21, or Edwards syndrome, which is trisomy 18. Types of trisomy 13. Full trisomy 13. The existence of a third copy of chromosome 13 in all of the cells. About 95% of cases of trisomy 13 are this type. Mosaic trisomy 13. the existence of a third copy of chromosome 13 in some of the cells. About 5% of cases of trisomy 13 are this type. Partial trisomy 13. The existence of a part of a third copy of chromosome 13 in the cells. Less than 1% of cases of trisomy 13 are this type. The disease process of trisomy 13. Chromosomes are the packages of genetic information made of DNA that contain the instructions the body uses to build a person. Chromosomes come in 23 pairs, with most people having 46 total chromosomes. Then, cells divide abnormally during reproduction and create extra genetic material on chromosome 13. Next one is chromosome 13 have 3 copies instead of the unusual 2 copies for a total of 47 chromosomes, which leads to this extra 13 chromosome affects the baby's development, resulting in a number of medical issues. For the assessment, risk assessment, non-invasive prenatal testing. It measures the fetal cfDNA in the mother's bloodstream, which comes from the placenta. We also have ultrasound examination. It is to check for physical features that are associated with trisomy 13 in the fetus. So these are the signs and symptoms of trisomy 13, which is divided to physical, cognitive, and others. So we have affected infants typically are unusually small, eye agenesis, various craniofacial malformation are frequently present, abnormally small head, sloping forehead, unusual wideness of the soft spot at the front and back of the skull, incomplete closure of the roof of the mouth palate, small jaw, scalp ulceration at the top of the head. We also have low-set, malformed ears, a short neck, and loose skin folds over the back of the neck. Presence of benign lesions or birthmark consisting of abnormal clusters of blood vessels, most frequently on the center of the forehead. Unusually small eyes is also observed and a partial absence of ocular tissue from the iris. There is also an abnormal development of the retina, which is called retinal dysplasia. We also have vertical skin folds over the inner corners of the eyes, and eyebrows may be sparse or absent. Extra fingers is also observed as well as congenital malformation. For the cognitive features, we have severe cognitive impairment, while other signs and symptoms observed is having feeding difficulties. Many infants are thought to be deaf and profound mental retardation is usually present. Abnormal tone of voluntary skeletal muscles and a congenital heart defects such as atrial or ventricular septal defects or patent ductus arterius. We also have kidney or renal defects and an hernia. The picture shows an example of an infant who experiences trisomy 13. For the diagnostic tests, we have fetal ultrasonography, which is potentially revealing findings that may suggest a chromosome disorder or other abnormalities. We have amniocentesis, which is a sample of fluid that surrounds the developing fetus is removed and analyzed. We also have chorionic villus sampling or CVS. It involves the removal of tissue samples from a portion of the placenta. Nursing diagnosis. We have imbalanced nutrition, decreased weight related to mobility to ingest food. As we all know, adequate nutrition is essential to meet the body's demands. Several diseases can greatly affect the nutritional status of an individual, especially when there is a problem in the mobility to ingest food. We also have impaired physical mobility, abnormal muscle tone related to cognitive impairment. cognitive impairment has been linked to measures of mobility dysfunction spanning the disablement process, such as poor muscle strength. We also have risk for injury related to surgery. Infants who have cleft lip palates need to undergo surgery. For the management, we have nursing actions, provide education about trisomy 13 as a disease and its associated complications. It is to help the patient's family know what are the complications and what are the possible effects of trisomy 13 to the infant. We also have ensure mothers and infants' comfort. It is to promote comfort and safety to the infant and to the mother. It is also to gain cooperation from the client. We also have provide emotional support to the family. It is to increase well-being, improve psychological function, and cause improvement to immune system function. For the medical interventions, we have intubation with ventilator to provide patient support for poor respiratory effort. We also have echocardiogram to check for congenital heart defect as well as chest radiography. It is to diagnose conditions affecting the chest, its contents, and nervous structures. For pharmacologic interventions, we have infant will be given anesthesia during surgery to provide pain relief. For the surgical interventions, we have nasoalveolar molding, which is to improve the shape and position of the lip and nose. With a smaller cleft, there is a less tension when the surgeon closes the cleft. We also have chyloplasty. It is the reconstruction of the normal anatomy and function of the lip, correction of the nasal deformity, and construction of the floor of the nose and proper alignment of the maxillary segments, or the gum line. We also have cardiac surgery may be comfort done for infants with heart defects. It is to repair heart defects. A child is born with congenital heart defects. We also have gastrostomy tubes for supplemental feeding. It is to receive nutrition and keep their GI tract working. So this is the pathophysiology for trisomy 13. We have the predisposing factors, which is the genetics, and we also have the precipitating risk factors, which is the maternal age and the family history. We have the etiology and its signs and symptoms. We also have the different managements, the nursing management, the medical and pharmacological management, as well as surgical management.
Good day, everyone. This is Ms. Rosen Bispo presenting to you Trisomy 18 or T18. Trisomy 18, also called Edwards syndrome, or 47XY18 plus for males and 47XX18 plus for females, is an autosomal chromosome disorder or abnormality that occurs during fertilization. Children with this syndrome have 3 copies of chromosome 18 with a low survival rate. Normally, each sperm cell and egg cell has 23 chromosomes. The union of each of these chromosomes creates a total of 23 pairs, or a total of 46 chromosomes, half of which are from the father and the other half from the mother. In some occurrences, though, an error happens when an egg or sperm cell is forming, causing it to have an extra chromosome number 18 instead of the usual 2 copies of chromosome number 18, making a total of 47 chromosomes instead. The extra copy of chromosome number 18 can come from either the mother's egg cell or the father's sperm cell. Affected by the single proven precipitating factor of advanced maternal age due to older eggs being at higher risk for abnormal cell division, trisomy 18 is caused by having 3 copies of chromosome 18 in the baby's body instead of the usual 2 copies. Spontaneously occurring during fertilization, and it is the second most common trisomy with an incidence of approximately 1 in 5,000 live births or 0.23 in 1,000 live births. The extra genetic material from the third copy of the chromosome disrupts the normal course of development of the infant, causing the characteristic signs and symptoms of the condition. There are three types of a trisomy 18 syndrome: full trisomy 18, mosaic trisomy 18, and partial or translocation trisomy 18. Full trisomy 18 refers to the existence of a third copy of chromosome 18 in all of the cells. About 95% of cases of trisomy 18 are this type. In mosaic trisomy 18, there is an existence of a third copy of chromosome 18 in some of the cells. About 5% of cases of trisomy 18 are this type. This error in cell division usually occurs early in embryonic development. For partial or translocation trisomy 18, there is an existence of a part of a third copy of chromosome 18 in the cells. This happens when an extra piece of chromosome 18 is attached to another chromosome. Less than 1% of cases of T18 are this type, making it the most rare among the three types. Shown in the slide is the disease process of trisomy 18 or Edwards syndrome. The single most important risk assessment performed in pregnant women who suspect their developing fetus to be at risk for T18 syndrome is prenatal genetic counseling. For genetic counseling, the risks are assessed based on the type of structural rearrangement and its segregation pattern, especially in women who have had a child with a T18 syndrome. If a parent is a balanced carrier of a structural rearrangement, the risk is substantially high. Risks or associated factors of trisomy 18 or Edwards syndrome include age and hereditary. The risk rises with increased maternal age. In hereditary, a personal or close family history of giving birth to an affected child also increases the risk. A small positive association of increased paternal age with trisomy 18, as seen in Down syndrome, has also been observed. In the infant with the trisomy 18 syndrome, there are both significant physical and clinical signs and symptoms or manifestations associated, such as a misshapen finger or toe, or misshapen fingers and toes, often clenched hands, which is when the index finger deviates or crosses over other fingers. This is also called overriding fingers. The soles of the feet may also be rounded instead of flat, as seen in the picture. This is also called rocker bottom feet. The neonate may also have markedly low set ears, prominent occiput or back of the head, contracted joints, undescended testicles in males and bicornuate uterus in females, a short sternum, cleft lip or palate, and they usually tend to be small for their gestational age or have a low birth weight. The most significant clinical signs and symptoms include being severely cognitively challenged, being born with congenital heart defects, have severe lung defects, renal problems, and various abnormalities of other organs. The infant may also have feeding problems such as a poor suction, low abdominal muscle tone, dysphagia, perforated anus, and the like. Seen in the photos are the most significant physical manifestations or signs and symptoms in an infant born with the trisomy 18 syndrome or Edwards syndrome. Significant diagnostic tests and findings to detect or diagnose disorder include non-invasive prenatal screening testing or NIPS or NIPT. We also have invasive tests, but first we will be discussing the non-invasive ones. So the first is DNA analysis or karyotyping. It is a test that evaluates the number and structure of a person's chromosomes in order to detect abnormalities and provide a picture of the family's genetic pattern. This can be used for prediction in future children. Next, ultrasonography. Through imaging, sonographic abnormalities are seen with two or more of the anomalies visually present in about 90% of the fetuses and two or more anomalies present in about 55% of fetuses with trisomy 18, done ideally between 18 to 22 weeks of pregnancy, many of which may include growth restriction, polyhydramnios, strawberry-shaped cranium, choroid plexus cyst, overlapping of fingers or hands fingers, congenital heart defects, omphalocele, and a single umbilical artery. Next, we have Next, we have cfDNA or cell-free DNA. It is a non-invasive screening test for abnormal amounts of chromosomes and microdeletions in fetal DNA, where blood is drawn from the mother to assess the fetal cell fragments found in maternal blood. This test is done at 11 weeks up, although this can also be done as early as 7 weeks, often used to look for chromosomal disorders. Then, we have nuchal translucency. The most common soft sonographic markers detected in the late first or early second trimester are increased nuchal translucency thickness and absence or hypoplasia of the nasal bone, identifying two-thirds of cases, as seen in the picture. By way of ultrasound or maternal blood draw, this screening test assesses thickness at the fetus's neck, helping to diagnose if the fetus has trisomy 18 or any of the other common chromosomal disorders. Moving on, we also have invasive tests that help detect or diagnose trisomy 18. So first, we have amniocentesis, an invasive test that is obtained through a collection of amniotic fluid containing fetal skin cells through the maternal abdomen or the womb, helping to determine chromosomal disorders like trisomy 18. Then we have chorionic villi sampling on the right, or CVS, another invasive test that may be offered to pregnant women 35 years and above of age, or to those whose genetic testing is abnormal, to diagnose chromosomal genetic disorders such as trisomy 18, done at 10 to 12 weeks of the woman's pregnancy. The sample is obtained from the chorionic villi that arise from trophoblast cells. We have here three priority nursing diagnoses. Number one being impaired swallowing related to behavioral feeding problem due to poor suction. Number two, ineffective airway clearance related to excessive mucus in the infant's passageways. Number three, risk for delayed growth and or delayed development, possibly evidenced by risk factor of genetic disorder. The common complications or limitations of neonates with the trisomy 18 syndrome upon growing include heart problems, respiratory problems, feeding problems, and infections. They are the most common problems leading to high mortality. Although most babies with trisomy 18 have problems that affect all parts of the body. Oftentimes, infants born with a trisomy 18 condition do not make it to their first year of infancy. However, reports have found a very few to make it to their fourth decade with proper palliative care. Among the most common palliative caring care provided for infants to survive infancy with Edwards syndrome are the following. First, assess for associated problems. This is to determine and identify complications that can negatively and further affect the health of the infant. Then, determine infant's ability to initiate and sustain effective suck. This is because weak suck results in inefficient nippling, suggesting ineffective movement of tongue and mouth muscles, impairing ability to swallow. Then, note hyperextension of head or arching of neck during or after feeding or repetitive swallowing. Auscultate breast sounds to evaluate the presence of aspiration, and prepare for or assist with diagnostic testing of swallowing to identify the pathophysiology of swallowing disorder. Then identify individual factors that can precipitate aspiration or compromise airway. Have suction equipment available during feeding or as indicated. Suction oral cavity if client is unable to clear secretions. This is to prevent aspiration. Then, refer to surgeon, gastroenterologist, or neurologist as indicated. This is for treatment such as reconstructive facial surgery, esophageal dilatation that may result in improved swallowing. For patient with impaired swallowing, coordinate with a speech therapist for evaluation and instruction. Provide a consistency of food that is most easily swallowed. Monitor intake, output, and body weight to evaluate adequacy of fluid and calorie intake. And consult with dysphagia specialist or rehabilitation team as indicated, because dysphagia impacts feeding. Assist client or significant others in learning specific feeding techniques and swallowing exercises. This helps establish initial knowledge of the client's associated condition. Next, establish routine schedule for monitoring weight and educate the parents about Edwards syndrome. Many parents find that learning as much as they can about Edwards syndrome helps ease some of their fears. Now, at present, there is no known medical cure for infants with Edwards syndrome, unfortunately. However, clients can benefit from early detection and palliative care once the infant is born in order to help sustain their needs. First is genetic counseling, as stated earlier, and then we have fetal echocardiography. Abnormal cardiac findings are detectable using echocardiography in most patients with trisomy 18. Provide nasogastric and gastrotomy supplementation because in infants born with T18, they usually require other methods of feeding due to difficulty coordinating the breathing, sucking, and swallowing, such as dysphagia and sometimes vomiting. Next, treat infections as appropriate, as these infections are usually secondary to otitis media, upper respiratory tract infections such as bronchitis, pneumonia, and urinary tract infection, with sepsis as an ongoing concern. Then, we have respiratory support. Respiratory problems such as upper airway obstruction, hypoventilation, and central apnea are the most common causes of mortality in infants with trisomy 18. Post-operative respiratory care is particularly important for these children. Some of the children may require post-operative mechanical ventilator support. Lastly, we have resuscitation and orthopedic management secondary to hemivertebrae. With parental wishes to support the baby's long-term and assessment of the infant's quality of life, infants are resuscitated when needed to revive the infant. In patients or infants suffering with scoliosis, orthopedic management may be needed secondary to hemivertebrae. There is yet no known cure for infants suffering from trisomy 18, as most studies only focus on providing palliative care as well as corrective surgery to lengthen and maintain the infant's quality of life. However, there are drugs provided post-surgery to support the infant as well as antibiotics to treat infections. Administered drugs is prescribed, such as indomethacin and or mefenamic acid for closure and prostaglandin E1 for maintenance of patients with ductal patency, which is a cardiac problem. While cardiac management is primarily medical, most infants suffering from heart defects require a diuretic and digoxin for congestive heart failure. For surgical management, corrective cardiac surgery helps increase survival rate in patients with trisomy 18 suffering from cardiac defects and is proven to be effective in preventing congenital heart defect-related deaths. Next, surgical repair of other congenital anomalies, such as an infant suffering with esophageal atresia which makes feeding difficult. Surgical repair is an option made available with proper prognosis. General, orthopedic, or otolaryngologic surgical procedures are also considered for patients whose anomalies fall under the categories. Chyloplasty is an option available for infants with cleft lip and palate. Seen here is a pathophysiology or overview of trisomy 18 or Edwards syndrome. Attached is nursing care plan for an infant born with trisomy 18. The priority nursing problem or nursing diagnosis is a physiologic deficit, which is ineffective airway clearance. Objective cues include ineffective cough, diminished breath sounds, excessive sputum, alteration in respiratory rate or patterns, and a cyanotic occurrence. Subjective cues include shortness of breath or dyspnea, and lisod ginhawa ako anak, as verbalized by the client's parent. The nursing diagnosis is an ineffective airway clearance related to excessive mucus in the infant's passageways. Scientific basis for the nursing diagnosis is that among the most common risks for trisomy 18 infants' mortality are associated with congenital cardiac, respiratory, and renal complications, with upper airway obstruction a more common incidence than previously realized. Coughing is a normal mechanism that allows to clear the airway of irritants that may have entered the system. However, an increased irritation of the respiratory system can cause both an inflammation of the passages and a marked increase in mucus secretion. This hypersecretion can lead to an impaired gas exchange and reduced mucociliary clearance, encouraging bacterial colonization and exacerbations of an associated disease. Objectives of care, we have both a general and specific objectives. For general objectives, after a week of holistic nurse to patient interaction, the client will be able to maintain airway patency. Next, for specific objectives, after 8 hours of student nurse to patient caring care, the patient will be able to demonstrate absence or reduction of congestion with breath sounding clear, noiseless respirations, and manifest improved oxygen exchange. Measures to promote adequate patent airway include identifying the client at risk. This is because the infant or child with feeding intolerance is at higher risk for problems with maintenance of open airways. Next, monitor respirations and breath sounds, noting rate and sounds, such as tachypnea, stridor, crackles, or wheezes, because these are usually indicative of respiratory distress and or accumulation of secretions. Next, monitor vital signs, noting changes in blood pressure and heart rate. This helps to perform interventions as needed. Then, suction nose, mouth, and trachea using correct size catheter and suction timing for child. This is to clear airway when excessive or viscous secretions are blocking airway or client is unable to swallow or cough effectively. Evaluation for our nursing interventions and objectives of care is after a week of student nurse to patient interaction, the client was able to maintain a patent airway and a steady breathing rate. Let us continue. Insert oral airway using correct size for child when needed. This is to maintain anatomical position of tongue and natural airway, especially when tongue or laryngeal edema or thick secretions may block airway. Next, exercise diligence in providing oral hygiene and keeping oral mucosa hydrated. Airways can be obstructed by substances such as blood or thickened secretions. These can be managed by strict attention to good hygiene, especially in the client who is unable to provide that for self, since our client is an infant. Next, monitor infant or child for feeding intolerance and abdominal distension, as this may compromise airway. Assist with procedures to clear or maintain open airway, and keep environment allergen-free. This is to reduce incidence of reactions to stimulants depending on individual situation. Administer analgesics to improve cough when pain is inhibiting effort. Note that overmedication can depress respirations and cough effort. Next, administer medications such as expectorants, anti-inflammatory agents, bronchodilators, and mucolytic agents as indicated to relax smooth respiratory musculature, reduce airway edema, and mobilize secretions. Increase fluid intake to at least 150 ml per kilogram per day within cardiac tolerance and may require IV in some cases. Encourage or provide warm versus cold liquids as appropriate. This is because hydration can help prevent the accumulation of viscous secretions and improve secretion clearance. Continue. We auscultate breath sounds and assess air movement to ascertain current status and note effects of treatment in clearing airways. Then observe for signs of respiratory distress such as an increased rate, restlessness, anxiety, or use of accessory muscles for breathing. This is to perform interventions as needed. Then document response to drug therapy or development of side effects or interactions with antimicrobials, steroids, expectorants, and bronchodilators. Pharmacolo- Pharmacologic therapy is used to prevent and control symptoms, reduce severity of exacerbations, and improve health status. Lastly, we observe for signs and symptoms of infection. This is to identify the infectious process and promote timely intervention. Thank you, and that is all for Trisomy 18.